Good evening, everyone. My name is Dr. Meg Green, and I'm one of the technical services veterinarians for ArthroMed, and we are so excited that you decided to join us this evening. It is my honor and pleasure to introduce our speaker for this evening. It is Dr. Matt Brunke, and he is the Director of Canine Sports Medicine and Rehabilitation at Veterinary Referral Associates in Gaithersburg, Maryland. And tonight he's going to be speaking on It's Not the Cartilage, It's a Synovium, OA Diagnosis, and Intra-articular Management. Turn it over to you, Dr. Brunke.
All right. Well, thanks everybody for taking time out of your busy schedules or trying to get home, or if you're listening to this on your drive home, please listen, don't watch. Or if you chose to stay at work late to listen to this and watch this, thank you for that too. Um, let's roll right into it a little bit as soon as my slides behave. Um, just a few disclaimers. I work for a lot of different industry partners in our field. Um, None of them had any intellectual property control over what I present to you guys tonight, but just disclaiming some of the very awesome teams that I get to work with. And that kind of folds back as we get into talking about a One Health topic tonight is we need to communicate more on what we're all doing. I actually had a phone call today with some zoo vets. We had a human orthopedic sports medicine specialist on it, and I was texting an equine specialist at the same time about the same case. So we need to be working from each other and learning from each other all the time. Tonight, we're going to talk about osteoarthritis because we don't talk about it enough. Because honestly, if you think about your vet school education, whether you just graduate this year or you graduated 20 plus years ago, like I did, you only get 1 hour on osteoarthritis in the second year of your education, and that is it. Okay, so when you feel like you don't know a lot of this stuff, that is completely okay. Okay, we can learn about it postgraduately because we don't get it taught during vet school. Okay, but OA is the number one cause of chronic pain in dogs. These studies are old, right? 1997, 2003. Okay, we figure that about 20% of dogs are affected in the US with osteoarthritis. Chronic pain, of course, decreased activity, yes, but increased rates of euthanasia, right? Interfering with the human animal bond. And look, as veterinary professionals, no matter what part we are, as technicians, doctors, specialists, whatever, yeah, I can understand we lose a battle with we lose a dog to metastatic osteosarcoma or histiocytic sarcoma, humane euthanasia, absolutely. But euthanizing animals due to chronic pain from arthritis, to me, is unacceptable. But we have to do better about figuring out what we can do to make it a better battle. Okay? This is a more recent paper, by the way, because I think it's always good to keep learning and keep current on what's out there. How much arthritis are we actually seeing? So this was a really small study out of NC State. It was 123 dogs, okay, which is actually kind of decent size for vet med, but still tiny, okay. And they said, where do you find arthritis and at what age? And here's one of the figures from that open access paper. Elbows and hips, okay, are the top two joints we see in dogs for osteoarthritis. Right? You think with all the TPLOs we do, you would think it would be stifle OA. It's not. And while with hips, we have a really good screening tool. Come find me if you ever want my lecture on pen hip. Okay. We don't have a great screening tool for elbow OA. But those 1 year old puppies, right, that are golden retrievers or labs or shepherds, and it's a thoracic limb lameness, trust me, folks, it is not a soft tissue injury. A thoracic limb lameness in my world is an elbow until proven otherwise. Because in that same study, look at the age in months. Okay. Dogs under 28 months of age, so barely over 2 years, made up 43% of the dogs in the study. Right? These dogs have radiographic OA before they turn 3. Right? So this is why you're all here tonight, is to learn more about it. Let's figure out and dive into it. Right? We're going to talk about osteoarthritis. We're not talking about immune mediated tonight or septic or neoplastic. We roughly think, from what we limited studies that we have, 1 in 5 dogs and 3 in 5 adult cats, we'll talk a little bit about kitties tonight, have radiographic OA. But yeah, it's hard to discern whether or not that's clinically relevant. But another study that was done, 31% of pet owners said bone and joint problems were an issue for their pet. So for those of you that work GP that saw 10, and I can hear you all chuckle, you saw 20 appointments today. But if you saw 10 appointments today, 3 out of 10 owners probably said that their problem was a mobility issue. So OA has to be thought of as a global disease process. It is not just, oh, it's an arthritic elbow. No, it's the final pathway of a failing joint, and the joint is an organ. And arthritis is something that's heading towards organ failure. And we're really good as VetMed about talking about chronic kidney disease, chronic heart failure, but we don't talk enough about joint failure. And in dogs, it's almost exclusively secondary. So what does that mean? It means, it's because of elbow dysplasia, because of a cruciate tear, because of laxity of a hip joint, we get OA. As opposed to our feline patients, where typically their arthritis is primary, which means it's the 17-year-old cat or the 13-year-old cat that comes in for arthritis or complaining about trying to jump up or jump down. But the pathophysiology of OA involves the entire joint. And I need you guys to stop thinking about it as a cartilage disease. Osteoarthritis, whether you're a human, an equine, a canine, or any other species, it is a synovial disease. And if you know your normals, you can know your abnormals. So on the left side of the screen, normal joint, on the right side, inflamed. But think about it, okay? The synovium is what provides all the nutrition to the joint. It is what makes joint fluid in its proper amounts and how deep, how thick it is and things like that and what's in it. It's the synovium that provides the life material to the joint, okay? Yet we all get taught in vet school that it's a cartilage disease. But we also get taught in vet school that cartilage does not have nerve endings. So sure, in that diagram on the right, that dog has very little cartilage left. It has exposed, right? Has exposed bone. So why is that dog painful if cartilage does not have nerve endings? Because the two things that do have nerve endings are number one, subchondral bone, but not every dog gets down to subchondral bone, right? And the most amount of nociceptors is in the synovium. So that is why arthritis is painful, and that is what the root of it all is synovial diseases. And so we get something that causes instability. That could be a cruciate tear. That could be we have poor genes and we have hip laxity. That could be that we have elbow dysplasia and we have a fragmented medial coronoid process. Anything that causes instability then leads to synovitis. That synovium gets stretched, inflamed, and aggravated. And that then leads to an overproduction of macrophages and synoviocytes, which gets us out of balance. Right? We then get more pro-inflammatory mediators, we get more cartilage destruction, we get pain. And we talk about this vicious cycle of OA, we all do, but I want you to wrap your head around it as this. The joint should have normal homeostasis. Right? We know that red blood cells have a lifespan, white cells have a lifespan, skin cells have a lifespan, and we all shed skin cells every day, but we grow new ones. The synovium, when it's balanced, will have proper amounts of catabolism and anabolism, and it stays in check. But what starts the vicious cycle is an imbalance. Too much catabolism, not enough anabolism to make up for it. And then the anabolism, that the growth that does happen, can't keep up with it. You can't try to grow new hyaline cartilage when you're down to subchondral bone. You're only going to grow fibrocartilage. So you don't have as much structural integrity, as much support when you're on fibrocartilage versus hyaline. So it is truly that the joint as an organ needs to have its own homeostasis. This is not just in the US. This was a paper out of the UK a couple of years ago. And what did they look at for elbow disease, right? Rotties, Labs, German Shepherds, and Goldens were the top 4 breeds. Okay, we can agree with that in the US. They found some other risk factors: older age, sure; larger body weight, sure. Interestingly, being insured is probably a red herring because the vast majority of pets are insured in the United Kingdom. But Owners complained that 1 in 5 owners said my dog had difficulty exercising. 1 in 7 said my dog was in pain. 3 out of 4 said my dog was lame. And I think we all see this too, right? Sometimes we have to convince owners, gee, the dog's hopping around on 3 legs, but he's not crying about it, so he's not in pain. So it's not just us in the US that has that disconnect with our clients. We need to do better about correlating that if the dog is lame, the dog is painful. And what really stinks in this study, right? The mild thing is 61% of cases in this were bilateral. That's fine. That's the same stuff we see in the US. But elbow disease contributed to the decision to euthanize in 41% of the dogs in this study. And this goes back to it, right? Human animal bond, why we all got into this. We didn't get into this to euthanize animals over manageable diseases. And we certainly didn't get into this to push pills. So we need to do better about our education and how to be good advocates. When we think about OA, of course, you get that thickening of the joint capsule. You get remodeling of that subchondral bone. That bone gets denser because it's being exposed to more force. And on radiographs, that will look like that will be sclerosis. That bone will be whiter, right? Osteophyte formation happens, sure, absolutely, okay? There's all these changes, not just in the joint itself, but the joint capsule and the bones around it in trying to deal with the fact that this joint is in failure. So where do you find these? Okay? On every exam you do, especially juveniles. Okay? Everybody bend your own elbow, extend your own elbow. You should be able to count to 5 in both directions. If it hurts in hyperextension or hurts in hyperflexion, you have joint damage. Right? If you feel on either side of your olecranon, with your elbow extended a little bit past 90, you should be in concave areas. If you're not in concave areas, if it's flat or convex, that joint is effused. And then you can take your hands like little claws and you can compare condyle width to condyle width. And if you had a wider joint, the wider joint is the more problematic joint. So this is something that when you get down to it, you can do an arthritis screening physical in about 3 minutes. Okay? Your techs are key to these because they come in for vaccines or ear infection and go, when was the last time your dog went up the stairs? Oh, it doesn't go upstairs anymore. It's old. I'm sorry. Age is not a disease, right? Why does a dog stop going upstairs? Because it hurts. So look at how these dogs stand. Look at what they're doing. I get it in GP. I did GP for a decade, 15-minute appointments, quadruple booked. You don't always have time. But get the owners to send you a video of how the dog walks, or take a minute and just watch the dog walk outside. Okay? Listen to how their footfalls go. Are they scuffing? Are they scraping? What are they doing? Because those cartilage damage and that synovitis occurs way before radiographic changes. If we wanted to break it down by joint, and by the way, I didn't say this at the beginning, if anybody wants a PDF of these slides, just email me later. I'll give you my direct email, so don't feel like you have to be taking notes. Okay? By joint, what diseases do we normally see? Elbow number 1, all the different components of elbow dysplasia. Hip dysplasia, stifles we talked about, right? Carpus, we don't see that much. We're pretty lucky. But think about it as developmental or trauma, right? So if you have hip dysplasia, that's developmental orthopedic disease. But you could also have a perfectly normal, tight hip, gorgeous elbow, and then that dog gets hit by a car and maybe gets a growth plate fracture or gets blunt force trauma to that joint. And now you don't have developmental OA, but you still have true degenerative OA. And thankfully in our world, things like infectious OA and autoimmune are really rare. You have to treat the primary disease as well. So if the primary disease is obesity, you have to treat that. If the dog has a blatant mechanical instability, you're not going to calm down the stifle synovium until you do a TPLO, right? And then primary OA in dogs will occur in the Manus and Pez, and those are less common, but they can still be treated really well. And anything that damages that joint capsule, that tears that capsule and synovium, allows then for synovial scarring is going to then lead to OA. So if you've done a good history and physical, still take radiographs. Okay. Radiographs are super helpful. I also joke, I was not born on Krypton. I do not have x-ray vision. So if I have an old dog, it's an 8-year-old lab, it's an 8-year-old shepherd, it hurts near its shoulder or near its elbow. Do you think it's arthritis? It probably is, but it could also be an osteosarcoma. So take some films. And to be honest, sedate and take films because they hurt. Right? The dogs are in pain. So sedate them, get them in really good positions, take appropriately positioned, well designed orthogonal radiographs, and get some info. Send them to a radiologist, post them on VIN, send them to me if you're not sure. That's totally fine. Okay. RADs do have some limitations, which I listed here, but they're still an excellent screening tool. By the way, if everybody's looking at this elbow, look at the size of these osteophytes. Okay. These did not show up yesterday. Okay. Osteophytes have to be almost 6 millimeters in size to show up on radiographs, 4 on maybe on really good ones, 3 millimeters if you're catching it on CT. Okay. So the cartilage damage had been going on for months due to the synovial inflammation. By the way, this is pretty gnarly elbow, right? Meg, I'm going to put you on the spot. Keep an eye on the comments in the chat. See if everybody can put in how old they think this dog is, and then remind me in about 10 slides, and I'll tell you how old this dog is. This is a Labrador. That's all you get to know. How else can we track pain? Okay, because our patients are nonverbal. Okay, if you've ever gone to PT, they give you this nice 10-question survey that says, does your pain affect your ability to drive a car, read a book, or sleep? And various things like that. Well, based out of Penn's Vet School with Dr. Dottie Brown, they validated what's called the CBPI, which is this simple, straightforward 11-question survey that you have the same pet parent fill out every time. And now you have a subjective method of how that dog's pain is interfering in its life and how severe it is. So this is something you can print off from this website tonight, and you can put into every consult and recheck starting tomorrow. Okay? It's what we do with every patient I see. But if we think about the pathophysiology of arthritis, it is a synovial disease, and we don't see synovium on radiographs. So the cartoon on the right, shows you how much cartilage damage because we're getting synovial hyperplasia. We're getting really severe inflammation. That's going to act basically like battery acid and eat away cartilage. If you've never seen synovium, here are 2 scope images. Okay, both of these synovii are inflamed. It's easy to pick out the red one, right, on the left, but even this one on the right, okay, synovium, both of these look like little sea anemones, and synovium, when it is healthy, should be completely translucent, okay? So these are both various degrees of synovitis. So yeah, how do we see that a little bit better? To some degree, we can see that with CT. And we'll call this dog number 2 because this is not the same dog as the radiograph from 2 slides ago. Okay. But if you want to guess how old dog number 2 is, okay, we can play that game tonight as well. CT is great if you have access to it. I love it because I can get both elbows and both shoulders with much more detail. Okay. But it does require sedation or anesthesia. And here's a key to really understand why we're still limited. We always talk about being reactive and not really proactive. Okay. This was a paper in Jones et al. 2023 in Frontiers. This paper has been on the last 3 sports medicine boards. And no, I'm not on the exam committee, but I just happened to, I didn't write that question, but it is there. It points out where we are in the timeline of OA progression. So on the bottom, we have reversible if we catch it early. Right? Painless and irreversible is stage 2. Painful and irreversible is stage 3. And end stage disease is stage 4. That's the green across the bottom. What I've highlighted is where both CT and plain films catch us. We catch it in the painful and irreversible stage. Okay? So most of the joints you see for arthritis are in end stage organ failure. Okay? We don't MRI many dogs for OA. and even that's kind of on the edge. Okay, and this is why sometimes when rads look normal and CT's really looking pretty normal, but the joint still hurts, we either do a joint tap and see what the cells look like microscopically, or we get arthroscopy involved and look inside the joint itself.
Hey, Matt, before you go
Yep.
on, do you
Yep.
want to answer the question to the one that you said regarding the radiograph that you saw?
Yep. So whoever guessed that that dog was 2 years old is correct on dog number one. Okay. So needle arthroscopy, if anybody's not doing it, this is a really, I just finished teaching a course this past weekend on it. Um, your big standing surgical scope towers are 150 to $200,000. These are like 30,000, so much more affordable. And we can do this under Dexmed and fentanyl. It gets us a chance to really look inside the joint and figure out what's going on. Okay. And if you haven't seen what normal cartilage looks like, on the left is normal cartilage. So it's nice and bright and white. And if I dropped a probe into this and I could push on that cartilage because it's normal, healthy hyaline cartilage, that probe would just slide off. There would be no problems at all. And then we get chondromalacia. Okay. So this looks pink because it's already inflamed. And if I put a probe into that, it's going to sink like a hot knife through butter. And then you start to get cartilage partial thickness fibrillation or even deep fibrillation, and then subchondral bone eburnation, which is the one all the way on the right. So this poor dog on the right, all of this pink area is all subchondral bone exposure. I'll spoil this one already. This is a 1-year-old dog all the way on the right, and that's an elbow. Okay. So these are tough. Okay. But this is where scoping, or if you're in rehab and you always want to work really well with your surgeons in your area, you want to find out what their scope reports are. So they are hopefully are grading how severe the damage is inside. They can also grade the synovitis as well. And in the video, we're just burring down to try to get to healthy bleeding tissue so that we can grow in some fibrocartilage. This is needle arthroscopy. This is also a 1-year-old dog. Okay. And here's just showing you like how thick and white and not translucent this synovium is. And then you're like, wait, hyaline cartilage should be white, right? Yes, you're correct. This is a 1-year-old dog that is bone on bone already. Okay. So this is pretty sad. This dog had a completely normal CT. No osteophytes, but horrible pain, not improving on NSAIDs, and we scoped it. And this dog obviously has a genetic disorder because somehow it just did not grow hyaline cartilage. Okay. How do you manage this dog for the rest of its life for 15 years? So the role of synovitis is critically important in OA, and these are just a handful of the papers looking at some of the aspects of it, honestly, mostly in human medicine in the last several years. Okay? And that's what I mean about learning from our colleagues and figuring out what works and what doesn't work. So how do we treat it? Okay, we treat it with NSAIDs, we treat it with amantadine, and then pre-GAB, opioids, and GABA all have question marks next to them because we have no published data to date that any of those three actually do anything for OA. Okay, intervention-wise, nothing replaces lean body mass and low-impact exercise, which is why those are bolded and italicized. And then I listed off a bunch of other things that we commonly use in vet med to manage OA that has some evidence for it. But honestly, what's the gold standard in horses? We're doing performance enhancing injections in horses. We're trying to inject them before they even damage the joint and be chondroprotective. That gets into a whole nother battle for another day. Or we're managing horses that already have arthritis and we're trying to keep them at their best. And then in humans, right? Yeah, you take your Advil, but then what? You don't really want to get a knee replacement at age 30. So we talk about things like hyaluronic acid injections, steroid injections, PRP. So why aren't we following the gold standards in both human and equine in our canine patients? And if any of you have ever tapped a joint to send fluid off to the lab, fantastic. You've done all the hardest parts. You got the animal sedated, you had it sterile prepped, you put a needle into the joint, you got fluid out. Great. But now just put something else in, right? You're there. Put something in to be a targeted treatment. Whether you do that percutaneous or Guided with ultrasound or fluoroscopy is up to you. Personal thought here is I always use Luer lock syringes because I want that nice tight seal. Okay. And the whole goal, I never tell an owner that my joint injection is going to be this magic panacea that's going to make it better. Okay. The goal is to make the joint better, calm down the synovitis. I can't make new cartilage grow, but if we can make the synovitis go down, the pain goes down, the joint feels better, now we can work on the fact of making the whole patient better. By whole patient means getting into rehab, getting from that BCS of 8 out of 9 to 5 out of 9. Right? And that's a whole nother topic for another day. But the vast majority of our pets not only have arthritis, but the vast majority of pets in the United States are morbidly obese. And by morbid, I mean 7 out of 9 or higher. Right? So we need to be better about not accepting that as normal and getting the weight off these animals, because fat not only puts excessive stress on joints when they're weight bearing, but fat contributes to that imbalance in homeostasis. Fat 24 hours a day, 7 days a week, makes little tiny cytokines called adipokines that generate more inflammation in joints. So whether you're sleeping and horizontal and not weight bearing, your fat is still working against your joints. The vast majority of joints I inject every year are elbows. So here's just how I get into an elbow. We do them sedated. We do them honestly out in surgery prep or an area. We find our landmarks and we fall right into the joint. Okay. What that looks like is this. I'll let this play for a second. This is a Labrador's elbow with an assistant. So I'm finding the medial coronoid process. And then I fall about a pinky's finger width caudal and distal. Have the assistant push the leg down to crack open the joint. Pop in the needle. Luer lock syringe. I don't fight for every 1/10 of an ml, but I want to get some fluid out because then I know I'm in. Okay. And then I disconnect that and I put in whatever injectate I'm doing. In this case, I'm putting something with a little bit of air because I want to make sure everything gets out of the syringe and into the dog's joint. Okay. And we've done this after we've taken radiographs and confirmed all of our disease, etc. So what can we put in? Okay, we all know in vet med nothing dies without steroids. So what do we know about steroids? Steroids honestly were the standard of care for dogs 20 years ago, and probably technically are still the standard of care for dog OA, is methylpred, Depo. It reduces synovial blood flow, so it's going to reduce synovitis. It's going to lower white blood cells and immunomodulatory responses in the joint, so maybe make us a little higher risk for sepsis. And it comes at the cost of cartilage degradation. So in equine, standard of care is triamcinolone and HA. So we can use Triam. It's actually less chondrodestructive than methylpred. So we could use that as well. Okay? But steroids, what do we know from our human medicine? Here's a systematic review and meta-analysis in humans that boiled it down that they found that placebo, aka saline joint injections, was more effective than steroids in humans. Yet steroids get covered by your insurance, which is why they're done most commonly. Okay. Now, some people will respond to steroids. I'm not saying no. Okay. But at what price and what long-term efficacy? Because for us in canines, probably steroids are working for about maybe 3 to 6 months. Local anesthetics. This was a paper out of Missouri's vet school. It was canine cadaveric study where they injected different things into canine joints and then dissected them out. Only triamcinolone and ultra dilute bupivacaine were safe. Everything else came at the price of causing more chondrocyte damage. So do be careful about putting things into joints as far as locals. Spring, folks you may have heard about. So what I tried to do is pull some of the recent research on what's around on different products. Spring is out there. It's a collagen elastin carbohydrate matrix. Apparently, and this is their claim on how it works. I do say claim because to date, I have no information through peer review or any white paper type stuff showing any of what it's made out of. It's a proprietary mix and there's no level of evidence. I do know that Colorado State's vet school is doing a canine elbow study that is completed, and hopefully that will go through peer review soon, and we'll see what that shows. PRP, platelet-rich plasma. I love orthobiologics. And why not take the body and put it back into it where its problems are? You can make PRPs, but there's a lot of different systems out there. We could talk for hours on PRP. But what we're doing is we're getting rid of the erythrocytes. We definitely need to reduce the overall leukocytes. I've highlighted that because that has been shown for intra-articular use. We do not want the same amount of leukocytes that are in the periphery, or concentrating their leukocytes would be bad for the joint. So we definitely need leukocyte reduced PRP, and we're hyperconcentrating the platelets and the growth factors to be a targeted anti-inflammatory. Full credit for this slide to my resident mate and friend, Chris Fry up at Cornell. Chris runs the stem cell and PRP lab up there. I said, Chris, can you send me all the evidence that we have for PRP for dogs with OA? And he goes, haha, here's the one slide. Okay. As you guys can see, there's about 10 or 12 papers out there. Some work, some don't. The average duration of effect is all the way on the right and is about 4 months. Okay. We still need to learn more. We probably need a series of PRPs, what we're now learning from our equine and human colleagues. What about stem cells, right? We all think stem cells are going to solve everything, right? We can just put these in and we're going to grow brand new hyaline cartilage. Again, full credit to Chris. Here are the studies for that. No, is the bottom line. Okay. Approximate duration of effect is about 60 days, and cost for this for owners is about $7,000. So we need a lot more studies on stem cells to figure out what we can actually be doing. Some of you may know about radiosynoviorthesis, so the use of a radioisotope to do a partial synovectomy and shave back the inflamed synovium. No, this is a non-systemic application. The little cartoon here is you put a radioactive isotope in, and the macrophages eat it, and they wither and die like Pac-Man getting stuck by a ghost. And they then move out of the joint after the isotope is inert. So this is Synovium OA. Not to spend a ton of time on this tonight. They have some studies on it. I'm a big fan of it, obviously, too. I've used it a lot. Small studies, 23 dogs, but they were the first of their kind to prove efficacy for up to 12 months with a single injection. So I think those are good things to be looking at, is how can we, if the process of sedating a dog and putting a needle in is all the same, what can we do that's going to give us our best chance for the longest duration of action and the most clinical improvement? CBPI was what they used as the primary outcome measure for the Synovium study, and this just shows you the dogs that were improving overall. And then the red line is when the isotope is out of their joint. So most of it is, 98% of it is out of their joint by 3 months post-injection. The PAGs, the polyacrylamide hydrogels, these are highly viscous, non-soluble, non-toxic, non-immunogenic substances that are predominantly sterile water, and then a cross-linked, in the case of the 2.5, a cross-linked polyacrylamide. Okay, and the 2.5% is Arthrimid, the 4% is Noltrex. Arthrimid has been shown to be stable in its augmentation effect into host tissue. And what that means is, so it grows into the synovium over a 14-day period. There are now numerous papers on that, which I'm not going to get into too much tonight, but if anybody wants open access papers or otherwise, just reach out to me or Dr. Green. And this goes into the synovium and acts as a bioscaffold for that return to homeostasis. So the synoviocytes invaginate into it and then present through the gel. So it's acting like a lattice for your tomato plants. It gives it some stability. And that's been shown in a couple of goat studies to actually be very effective in creating stability of that inflamed joint capsule. Not to flash back to organic chemistry too much, but the 2.5% is a cross-linked polyacrylamide. So acrylamide, yes, is a carcinogenic substance, but once it's cross-linked, it's not going to degrade. And when it's cross-linked, it is not carcinogenic, of course. It is also something that is going to then stay permanently in that synovium. but it's not like you're going to see it. It's not sitting on top like icing on a cake. It is the entire cake is now stronger because of the scaffold inside of it. It's considered a medical device in the US and it's used in different species. So the same 2.5% cross-linked polyacrylamide hydrogel is used in multiple areas. In people's faces, it is used as known as Aquamid. It's also used for HIV patients. HIV patients on antiretroviral therapy. The one of the side effects of antiretroviral therapy is a loss of facial muscle mass. So these were injected into people's faces and were shown to be effective to restoring their ability to smile. Okay. It's used in people with urinary incontinence as Bulkamid because it can get injected ultrasonographically or cystoscopically into the urethral sphincter. And since it will permanently stay in that submucosal area, now that sphincter, when it closes, it'll close all the way because it's a bulking agent. So people don't leak urine, right? And then in the equine and canine world, it's known as Arthrimid and has been used in horses since 2009, and now is also being used in both Europe and in Canada for human joints as well. So we'll get into some of looking at that research. But again, the job of the 2.5% IPAG is to be that scaffold to reset back to homeostasis. So the human data on this, this was a study that looked at taking the 2.5% polyacrylamide hydrogel, injecting into people that had severe knee OA, and they showed that it could be effective for up to 1 year in the original low dose. This is going back 2018 already. So this is stuff that's been around 7 years in people. They said, well, is it as good as the standard of care? And the standard of care in humans is hyaluronic acid. So they said, okay, let's compare HA to Arthrimid. And there was a statistical significant difference in the outcome measures. And both groups got out to 12 months, but there was a better response in the arthrosamid group. They then said, well, what if we track those out, right? Do you need a re-injection at month 13? Or when do you get painful again? And as you can see here, they started with 49 patients on day 0, and they've been able to track out 29 patients to year 3, single injection on day 0, right? So yes, some do drop out. Maybe some need a knee replacement. Maybe some are lost to follow-up. But these patients, 3 out of 5, so 60% of patients are still comfortable year 3. And that actually is now out to year 4. I need to update this slide. So on the canine side, okay, this all comes, actually, that's a good point. Whether you're a human, a horse, or a dog, it only comes in one size syringe. It's a pre-filled 1 ml syringe. You want to use that syringe. They engineered their own syringe to get complete emptying of the product because it is so viscous. So humans get 6 ml, so they use 6 syringes. Dogs, the dosing is up here on the right side. You inject it through a 20 to 23 gauge needle. Okay. Oops, sorry, that's a repeat. My apologies. I don't know what my slide deck's doing. Sorry about that. So that was a repeat of the human data you guys already saw. So let's look at some of the canine data. This is some unpublished abstract level work that was done a few years ago. They took 20 client-owned Labradors with moderate to severe OA, either using what we already talked about tonight, RAD, CT, or arthroscopy. They had good outcome measures, and they found that 75% of patients improved during the first 4 weeks. Okay, so it does take time. This is not a light switch. I always tell owners, if I put in cortisone, it's either going to work or it's not in 48 hours. PRP, 7 days usually is kind of what I'm thinking when I'm looking for improvement. This could take a little bit longer because of its different mechanism of action. This is some data that we're actually gotten out to full manuscript and it's going to get submitted to JAVMA shortly. We did a retrospective analysis of 100 owners representing 150 joint injections. 85% showed symptom relief, including 63% of patients were able to reduce or discontinue adjunct medications like amantadine or gabapentin. 44% of the patients in this study were able to reduce or discontinue their use of NSAIDs. Very few had short-term side effects where like transient joint soreness was reported. Sure, that I think that happens with any, has the potential to happen with any joint injection. And 90% of clients did say that they would do it again if recommended. Then there was another observational study. It was 50 dogs with 102 individual procedures, and they tracked these dogs out to about a year. Okay, 67% of the dogs treated were able to reduce or discontinue their systemic meds, and 75% or more, the majority of cases showed a 75% or more improvement in their orthopedic exam. So I think there is long-term potential, like we're seeing with humans, there is long-term potential for Arthromed in dogs. For sake of brevity tonight, I am not going to get into all the equine papers, but there is a ton of equine data as well, which I know Dr. Green would be happy to go over with you. What are contraindications? Don't use it in an actively septic joint or neoplastic joint. Be a good diagnostician and know what you're dealing with first. Okay? Don't use it in an infected area. If you get it outside the joint, it's not going to hurt the patient, but it's not going to help them. It used to say on the package insert, do not use in combination with other products on the same day. However, I keep this slide in because now the data has advanced that this is now off. This is no longer a restriction. There's an equine paper already published open access in JAVMA that concurrent use with betamethasone and Arthromed showed no adverse effects. And we are working on submitting for peer review, a retrospective study of combining different biologics or steroids with Arthromed in the same canine joints on the same day. And the white paper status on this is there's very few adverse or very few to zero adverse events. So we really, this hopefully is now off the package insert recommendations. To show you a dog who's kind of fun, right? I think seeing is a big help here, right? This dog on the left, right? She's not enthused. She's kind of, squinting at me, but look at her posture on a well-tractioned floor, right? Her back legs are out behind her and her elbows are externally rotated, right? 3 months later, so this dog had elbow disease. She had a CT. Scope wasn't warranted, okay? Which gets into a fun topic of sometimes there's some papers that skeletally mature dogs between 3 and 8, they took half of them and scoped them and half of them and just did conservative management, and there were no major outcome differences in a small study of dogs. So this owner elected to not have their dog scoped because scope didn't look like it was going to make a big difference. We injected Arthromed into her elbows. Look at her 3 months later, voluntarily keeping her elbows in the correct position. But what was she looking like walking wise? So granted, two different, big blatant head bob. I'll play it again. Okay. And then a couple of months later. Okay, now granted, yes, slick floor inside, concrete outside, but videos are videos, we get where we can. This is a dog who now doesn't take NSAIDs and has lost weight. Great job on her family's part, and is way more active. So my personal experience with this, it was originally known as Synovium, so I was using it, gosh, now almost 3 years ago. I've used it well over 1,200 doses now, mostly in elbows, but with some other joints as well, and predominantly in dogs. But I told you we'd talk a little bit about cats. I have used this in 10 cats to date, mostly in elbows and hocks, and have had similar results as what I'm seeing with my dogs' patients. And I've also been able to use it in conjunction with some awesome zoo colleagues of mine, in various species in some zoo animals, and then some other colleagues have also used it in zoo animals. I'm not the only one, but we've seen it in the fact that a joint is a joint is a joint, and a synovium is a synovium. So how can we do best as a One Health approach? So this can help a lot of different animals. I am in charge of the prospective study. So looking at like what the Synovium study did with 12 months study, right? Can we track out Arthromed by itself without combining it with anything else? We're in the middle of wrapping that up as well using CBPI. We had spots for 20 dogs. We got 18 dogs into the study, and we're tracking those out. There's the timeline on that, and the 90-day data gets submitted to ACVS as an abstract in about a week or so, and the 12-month data will finish data collection November of 2025, and we will get that into JAVMA for 2026, hopefully. For cats, I don't want to play this video right now, but just to show you, we don't have a lot of options for cats. There was one paper on PRP for cats, but it was only a 48-day outcome. Stem cells for cats have not been studied for OA. Silencia, the monoclonal antibody, that's a whole nother discussion for another night. I do epidural steroids in cats. I do epidural steroids in dogs because it is not a synovial joint, but we still get LS disease. So we'll put different things into that LS space. Okay. And then I do a lot of cats with either Arthromed or Synovium are my two things that I can grab off the shelf because trying to draw 13 mLs of or 15 mLs of cat blood and then spin it to PRP before it clots is, let's just leave that as challenging. In summary, I don't really want to leave time for questions, and I know that you guys can go back and listen to this again. Like I said, I will provide PDFs of my slides. Be a good advocate. Be proactive, not reactive. Do a solid physical exam on as many patients as you can. Get into feeling what joints should be, whether they're not effused or mildly effused. Realize that you can flex an elbow on any animal and it shouldn't hurt. So you have that 6-month-old or 1-year-old golden and you gently flex its elbow and it cries and that's repeatable. It's not a soft tissue injury. Okay. It's a joint disease that you can go find. Okay. Be as proactive as we can. And yes, tell these owners that their dog is fat. Because if we don't get these dogs back to lean body mass, we have less chance of improving them. And that doesn't matter if you're a dog or a cat or a human, we've shown that. But I think targeted injectable therapy needs to become the standard of care for small animal medicine. And we've got good evidence from a number of injectates and we keep learning more about what we can do to get these animals the relief that they need without having to challenge them systemically. And future research is always needed. So with that, the second dog that we totally forgot about, the second dog with the CT scan with those horrific elbows, that dog was 9 months old. Okay. So how do I manage that dog when I can't do bilateral total elbow replacements? Okay. We manage these all together. Okay. We are a team on these. Here's my direct info. I'll leave that up and then I will bounce over to the Q&A section. Or how are we running this, Dr. Green?
Well, first of all, I want to say thank you for a great presentation, Matt. That was awesome. I think just anybody, can learn as we, have certainly learned so much over the years and everything, but really just the review that you gave us. And I think your comments of being proactive versus reactive, are a great place to start. And especially with the young animals and things like that. So we don't have to wait till they're 9 or 10 and your average age of patients that you're seeing is 10 years old, I think, last we spoke. And so it's be a lot better if we could have them a lot sooner to be able to take a look at before then. So thank you for that great review. With regards to the Q&A, we do have some questions in the Q&A. So if you're okay with that, I may just start with that and then
Go for it.
some things
Go for
that
it.
come up. And if anyone that would like to add some questions, the bottom of your screen, there is the Q&A section, and we'd be more than happy to go through this information and discuss that. So the first question comes from Dr. Iverson. Says, if you have Arthromed and Synovium available, how do you pick your patient? Is one of these products better for a certain type of patient?
Yeah, that's a great one. I don't know that answer yet. I think you really need to look if the owner has to have their dog sleep in bed with them and they can't follow the nuclear medicine rules, then Synovium's not an option for them. Also, I want to really emphasize the fact that if I have a dog who is 2 years or younger, my gold standard go-to first is CT to confirm the elbow, and then I send the surgeons in to do damage control, congruity issues, remove the coronoid, etc. And then I follow up with injections. Okay. When they're 13 years old, no. When they're 4 to 8 years old, I'll inject first. If we don't get better, I send the surgeons in to try to do damage control. So for the answer in the question of Synovium versus Arthromed, what did the CT look like? What's the signalment? What's the did we scope it first? If I'm getting a two dog, I'm probably going to scope it first to get those coronoids smoothed down, subtotal coronoidectomies, because otherwise we're not necessarily setting ourselves up for success by asking synovitin or arthrimid to do something that it's not designed to do. Both of those work on the synovium, and if there's a giant fragment crushing around inside that joint, that's a macroscopic problem that we need surgical intervention for.
Excellent. The next question I think you answered, but I always get this. This is a very common question that I field pretty much on a day-to-day basis when it comes to arthrimid use. In regard to, can arthrimid and PRP be used together?
So I get yes. The short answer is yes, but that is strictly from my own clinical experience and some of my other colleagues. Those colleagues are both equine and canine. Um, so right now, because we have two different mechanisms of action, PRP is an anti-inflammatory. Arthrimid's going to go in and try to and restoring the synovium and the scaffold there. Those are two different MOAs, so we can use them, and they work differently, and they work on different time points. So the PRP gets this in within a week or two, and now we can remodel that synovium with the arthrimid. So yes, I do it all the time. I have discussions with my clients about expectations, and obviously it's increasing day of costs, but it's also saving us a second sedation 4 6 weeks later to bring back with the arthrimid. So I think yes, you can do both on the same day. I would not do synovitin and arthrimid on the same day because of how long the synovitin stays in and different mechanisms of action. So I would not do synovitin and arthrimid the same day. I don't do anything other than synovitin. I never combine synovitin with anything else the day I inject that.
So the next question is, are you using shockwave post-arthrimid injection? And if so, when is the frequency?
I love Shockwave. I use it all the time for various things, but per the recommendations and understanding this, I don't use Shockwave over injected joints with arthrimid for 6 weeks. Due to the current understanding that, Maggie, if you want to expand on it a little bit, you know the better than I do. I just know to listen to you.
The biggest reason is out of caution. So if you want to use it ahead of time prior to injection, you certainly can. But the integration process we know takes start initially the 14 days and it integrates over the next 4 to 6 weeks. So we typically recommend that you wait up to what Dr. Brunke just said, which is that 4 to 6 weeks, just to wait and make sure if you're going to do the shockwave not around the joint that was injected. But if you have other soft tissue areas that are not obviously directly over that joint, you certainly can utilize shockwave at that time. But that's typically what we recommend as far as that's concerned.
Okay.
The next question is, you mentioned Noltrex. When do you
Mhm.
choose it?
I have not used Noltrex in my entire career. I don't. I can't find any evidence to support its use. Um, and in talking with so it's not available for humans at all. And in talking with my equine colleagues, the vast majority of the equine colleagues that I have talked to don't use it and don't recommend it. And to my knowledge, there's no data published on any species on Noltrex's efficacy.
Another question that came up is, how soon after surgery of a joint can you use arthrimid?
Um, I would want to have a great discussion with the surgeon doing that at the time. I think this depends a little bit about what joint surgery. Are you closing the joint? Are you closing the synovium? Like we talk about when we're doing needle arthroscopy, we take deep bites of the sub-Q, but we're not like our equine colleagues that can find the actual synovium and close it. So we want to make sure that the capsule is healed and sealed so that none of our product leaks out so that not that we just don't want that patient's arthrimid to leak out and then not help the patient and get a false negative outcome. So I would say 4 to 6 weeks post surgery in the same range. Meg, where's your thoughts on that?
Typically, what we've seen, what we recommend is exactly that. When they come back in, if let's say you're considering this for say a post-op TPLO case, this is something that many of our surgeons, when they come back in and do the recheck, and clear them for that, that's when they are actually putting in the Arthromed at that time when they're coming back in for those sedated radiographs.
Mhm.
Another thing is if you are doing TPLO surgery at the time of surgery, the contralateral limb, so not the limb that's having the surgery performed on it, but the opposite limb, we also know that that's going to be the compensatory limb if it's not already been one. Prior to that, the synovium is also inflamed in that particular joint, and so a lot of times we're having surgeons come in and at the time of surgery they're doing that contralateral limb and injecting the stifle at that time there. And then, like I said, coming back in 4 to 6 weeks and reevaluating the one that they did post-op and doing it then too. So just trying to be proactive in that contralateral limb to preserve that, knowing that in the future, likely, as we all know, the risk of it failing is pretty high. And so we want to make sure that we're trying to stay proactive and help the patient for the long-term
Mhm.
effect.
Mhm.
So we have a question here. It says, for a 10-month-old burner recently diagnosed with hip dysplasia, are joint injections something that you would consider throughout lifetime for the management, or are you focused primarily on rehab and weight management?
The answer to that is yes, all of the above are true. I'm always going to focus on rehab and weight management with hip dysplasia, with any OA management, of course. Um, but what I'm also going to look at is how severe is this hip? Now, hips, I think, are one area, and I'm not saying every client can do this, but when I have a dog with significant enough hip dysplasia, I have a very blunt conversation with them about meeting with a total hip replacement surgeon, not committing them to surgery, but having a conversation. Because hip dysplasia with a THR is one of the few mobility diseases in vet med we can cure. We know we can pop a hip into a 10-month-old dog, and that dog should hold up that hip for the next 15 years. So I always say, do you want me to sedate and inject on a regular basis? Or do you want to go, if appropriate, if the surgeon thinks and the client thinks appropriate, spend a whole lot of money up front, but solve this and be done with this. So I don't go jumping to putting a needle in a joint on a hip because in human medicine, we do know that with that we have to be cautious about repeated hip injections because it puts them at higher risk for THR complications in humans. And I believe that has been shown in dogs as well. So I just have an honest conversation with them first, see what the simple steps do. And if a THR is completely off the opportunities, then yeah, I would bring that dog back and sedate it and inject it because I'd rather manage that OA and minimize, hopefully, right? Minimize that, being proactive and trying to minimize that synovitis versus having to take that dog and put that dog through an FHO, like, at a year or two of age because it's just out of control.
The next question that we have is, would it be wrong to use Arthromed at the time of suspected CCL diagnosis and surgery? Will it be delayed for 4 to 6 weeks?
You, I don't think it would be wrong. Um, I think it's a really interesting question. Like if your TPLO surgeon's booked out 8 weeks and you sedated a dog and got a cruciate instability, could you put in Arthromed then? You're borderline on being proactive, which is awesome. Um, I think the key there, and again, you're dealing with the hydrogel, it's invaginating in. The thing that kind of popped up on the equine side a couple of years ago was, are we putting these animals at a higher risk for septic arthritis? And I'll just say that I haven't been talking with a bunch of equine colleagues that really is a non-issue, that it does not put them at higher risk. But I always just have a good conversation with my surgeons about, hey, do you want me to inject a joint before you touch it? Or do you want to wait until after your job is done? So just having good communication with your surgeons, I think is key, but I don't think it would be wrong, especially if you're the veterinarian who is going to be doing that TPLO in 4 to 6 weeks. If you're comfortable with it, I don't see a big deal at all. You're doing a good surgical prep, you're using sterile technique. I wouldn't see a problem with it.
The next question is sort of along a similar line, but it said, would it be helpful to do arthromed in a knee with a suspected partial tear?
Again, I don't think it's going to hurt. I mean, there was a study in JSAP that looked at doing PRP for partial tears, and at the time of the other one getting a TPLO, and didn't see much improvement. We're still asking a lot. Like the synovium is a driving force in a cruciate problem, but you still have if you have massive mechanical instability, and the owner goes, "Oh, gee, you put 2 mLs of PRP or you put 2 mLs of Arthamid in, and it didn't do much." It's being, I like it as best medicine. I think that we should look at it more. And there was a really cool paper looking in both humans. Well, I'll get to that in a second. I think it would be good. I just would be exercising and setting up proper expectations with that owner. It is not going to solve the mechanical instability of a cruciate tear.
I agree. Another question, Dr. Bauer asks, are there any studies evaluating of injecting contralateral limb at the time of TPLO actually reduces incidence of ACL tear in that limb? Unfortunately, no, not at this time. There is not a paper. So everything we just talked about is anecdotal information that we have talked to surgeons that have been utilizing Arthromed at the time of surgery, but definitely something that we would certainly welcome the opportunity to eventually take a look on. I can tell you that Matt more so than I at times always has a running list of what he has on a whiteboard of studies that he would like to do. And I know this happens to be one of them among many others.
Mm-hmm. The hard part with that one, Beth, is remember too, dogs that have a tear one cruciate have a 50 to 65% chance of tearing the other one within 24 months. So it is a long way to track them out.
All right. That's all the questions that we have in the chat, but a couple things that I think might be helpful that I get on a regular basis that I would welcome your input on and some insights, certainly with your experience with utilizing Arthromed specifically is, when we talk about volume. And some of the things, that come up frequently is, we have our dosing chart and that kind of thing, and that's based on response to therapy. So what is your thought, Matt, in your experience of let's utilize elbows as an example of we have the range of 1 to 2 mLs. Is there anything
Mhm.
that you might provide some insight with regards to your experience with using injectates in elbows and or stifles?
Yeah. Yeah, yeah. It's a really good question. There was a paper that just came out, not to sound like a broken record, but when we actually do have a paper that's helpful. There's a paper that came out that looked at canine cadaveric elbows and scoping them and how much volume you could put in and how much it would leak. And they found that things over 4 mLs would leak out. So when I'm looking at your average 75-pound lean body mass Labrador, right? That's the most common dog I inject. That's the most common size elbow I inject. I'm not trying to exceed 4 mLs. Okay. But if I'm doing steroid, I get the 40 mg per mil stuff because that's ultra concentrated. Um, and then I'm probably leaning closer to 2 mLs because in the human study for Arthromin, the original study was 3 mLs per stifle. Okay? And they found that most people did well, but some did need a top off injection. And then now they do 6 mLs per stifle. So I would rather just put the second ml in a dog's elbow than have to resedate them 4 to 6 weeks later. I think it's better for the dog. It's better for the owner's pocketbook. It's better for the owner outcome. And that's what I've been doing for over a year now and I knock on wood, I don't have dogs that I re-inject a month later. We've done really well with that. And then as we've moved into combo therapy with PRP, I'm doing PRP, so 1 to 2 mLs of PRP and 2 mLs of Arthramid in your standard Labradorish size elbow. I do not have any joint flares. I do not have any adverse reactions, knock on wood. And I'm really happy with my outcomes. So I'm doing the more is better up front to avoid that second sedation.
Okay.
Because in humans, guys, right? Like, what do they do in humans? You walk in, they tell you to stare at the ceiling, and they stab you with a 3-inch spinal, 3-inch 18 gauge needle into your knee. Okay. Horses, standing sedation, giant joint. Okay. It's not our world in small animal, right? Doing these under sedation, bring them back in. They're not always easy joints to get into. If I've got it there, I also will do it to tension. So if I can put my aqueous substance in, I'll put a 1 ml of Arthromed in, I'm not jamming this. I'm riding that plunger down. And when I get kickback, okay, it's time for me to stop.
Okay. Another question that comes up is, what if I get it outside the joint? What happens
You
then?
get it outside the joint, you're not going to help the patient, but you're not going to hurt it. Okay, you can see with humans, right? You can inject this into their muscle, their facial muscles and their urinary bladder. So you're not going to hurt them. There's 7 and 10-year safety and efficacy data on that for humans, that you're not causing a problem to the localized soft tissues, but you're not helping the patient. So being sure you're in a joint is critical.
Another question that comes up a lot is when we talk about, what happens, and you mentioned it in regards to some of the patients that you saw, is post-injection. Like, what is your post, injection protocol? And what if you do end up having a problem? What's the most common thing that you see occur?
Yeah. So the benefit of doing, let's leave it as just Arthromed, right? The benefit of doing just Arthromed is I don't take them off their NSAIDs ahead of time, and I don't take them off their NSAIDs for a couple of weeks. So I think that contributes to why I probably don't see joint flares, is they're already on pain meds. If I inject them, I see them back 2 to 4 weeks later, repeat my physical, watch their gait, see if we're improving, and get them into rehab. And then once they're doing well, I may start to try to dose reduce their NSAID. Okay. Um, that's my go-to on those. What other part were we thinking about, Meg? What did I miss?
So like, as far as like, what's your post-injection protocol specifically with your dogs? Like, what do you have once you inject? What do
Oh,
you do with your
I
owners?
mean, they go home same day. I don't, they can ice pack the joint if they need to. They stay on their NSAID, and they're on, I like them to be not trotting, running, galloping until I see them back at that 3-ish week mark. But 24 hours later, they can be hand walking, to borrow from equine, they can be hand walking them, 10, 15 minutes. Most people aren't walking their dog 15 minutes a day anyway. But I just don't want them out chasing the squirrel or doing anything else. It's just controlled activity for the first 3 weeks while we're getting that Arthromed to integrate into the synovium.
Absolutely. Let me check if there's any more additional questions in the chat. I don't see any more questions at this time from anyone. I appreciate all of the hard work and effort that you put into tonight's presentation, Dr. Brunke. It's certainly been a great overview of OA and reminding us that, it is not the cartilage, it's the synovium that we need to be thinking of and really being proactive. I think we got one more question that just popped up, possibly. Oh, it was just thank you. It was great.
Thanks everybody for taking time out of their busy schedules. I know it's chaotic. We're all busy as heck. Feel free to reach out to me directly, reach out to the awesome team here with Kentura. Keep learning. I know we have a couple other folks doing webinars this year, so sign up for those and we all keep learning together.
Awesome. Thank you so much. And thank you all for joining us tonight. We certainly appreciate it. And if you have any questions or concerns, please don't hesitate to reach out to us. I'm more than happy to do case consults with you to help you and get you started doing intra-articular injections and targeted therapy for your patients. Have a great night.